Today we will teach you on the management of the ATLS, Advanced Traumatic Support. So first, of course, we need to go to do the primary survey. What the primary survey for you to do the A, B, C, D, E, airway, breathing, circulation, disability, and exposure. So the main focus for us to do this primary survey to find and to check is it patient have any life-threatening condition, namely is atom TC, the pneumonic, airway obstruction, tension pneumothorax, open pneumothorax, massive hemothorax, T bronchial injury, and C cardiac tamponade. Okay, so first I will teach you how you want to do this A, B, C, D, E. First we will do the airway. So airway maintenance with cervical spine protection. So I will teach you how you want to approach the airway first. So first, how you want to assess the airway in 10 seconds. So you can ask directly to the patient's name and what happens during the trauma. Okay, encik, saya Dr Zahir. So apa yang jadi tadi, what happened, apa nama encik dan apa yang berlaku sebentar tadi. So if the patient able to tell you his or her name and can tell you what happened during the trauma, so we can assume, so we can emphasize the patient have didn't have much airway problem, airway able to maintain, no much breathing problem because patient able to generate enough volume of the airway to produce the voice, and the G-chest is full throughout the event. So airway maintenance. So if patient able to answer your question, so we can say airway is protected, airway is maintained. Then next, during this airway assessment, you also need to do one procedure named to put cervical collar application. Okay guys, this is the cervical collar, flexible cervical collar, because we can adjust this cervical collar according to patient's length of neck. Okay, so you can see like this. Okay, so to apply this cervical collar, you need to measure the patient's neck. So how to measure? So to measure the cervical collar, you need to measure from the chin, patient chin downward imaginary line into the base of the neck. So using your own finger to measure the neck. So for the patient chin to the patient base of neck. So from my finger, this become 3 fingers. Okay. Then later you take your cervical collar. So this your cervical collar is flexible, so you can measure. So if you can see, there's 4 different sizes. This one for the no neck, this one for the short neck, regular neck, and tall neck. So how you want to measure? So you want to measure from this blue plastic, not the white form. So from this one, just now you already measure by your finger, so it's 3 finger. So from the blue plastic, then you measure, so they become the 3rd one. So you adjust. So you need to open first the clip. You open first the lock. So you open the lock, then you put on the 3rd size. Okay. So they already fixed already your cervical collar. Next, how to apply. So this is Dr. Khadijah. Dr. Khadijah will help me to apply this cervical collar. So Dr. Khadijah, please you immobilize the patient head. Make sure in the neutral position.
Alright, I'll hold on to the patient's shoulder and use my forearm to stabilize the patient's head.
Okay. So next, what you need to do. So you see there's a straight base on this cervical collar. So this one you need to slide below the patient's neck. Okay, Dr. Khadijah, I will start to apply
Okay,
So-
I'll fix to the patient's forehead like so.
Okay, so I will slide a bit, slow until you see this styrofoam, the white foam on the other side. Okay, so after you see, so you just properly apply the cervical collar, then you straight. Okay, then make sure already like fix over the patient's neck, and your assistant can remove the hand from the patient's chest. After you apply the cervical collar, so you want to check for the fitness. Make sure you can allow to pass through one fingers below of your chin, below your angle of mandible. So if like that, so it's quite fit, and you already complete your cervical collar application. Next, I will proceed with the breathing. So breathing and ventilation. So during the breathing, your assessment is same as your respiratory examination. Start with your inspection, palpation, percussion, and auscultation. So during this breathing assessment, then you need to rule out another 4 injury. First is tension pneumothorax. Second is open pneumothorax. Third is massive pneumothorax, and fourth is the tracheobronchial injury. Okay, so I proceed with the breathing assessment. So I will start with the tension pneumothorax assessment. So okay, this is your patient. Of course, you need to open up the patient clothes to expose the chest. Then the first thing for the tension pneumothorax, so I go because of the examination is same as your respiratory examination, so I will try to go straight to the patient, the sign and symptom of the specific condition. So first I will go for the tension pneumothorax. So for example, if the patient having the injury tension pneumothorax over the left side. So sign and symptom, first you can see during inspection, patient is tachypneic in respiratory distress. So then patient having tachypneic, fast breathing. Then you open up the chest, then you will see there's a patient respiratory is tachypnea. Then you can see from the inspection there's a reduced, as I mentioned just now, if the injury over the left side. So you can see there's reduced chest movement over the left side. Then you can see maybe there's some wounds, some bruises, or any sign for injury over the left side of the chest. Then at the same time, don't forget about, you need to check over the patient's neck. So during inspection of the patient's neck, you can see there's a dilated neck vein bilaterally for the tension pneumothorax. Next, finish your inspection. So you go for the palpation. So palpation, what you can do next is you can do the chest expansion. So you chest expansion for the patient. Ask the patient to breathe in, breathe out, breathe in, breathe out, breathe in, breathe out. Then the finding is there is a reduced chest movement or reduced chest expansion over the left side. Next, over the neck, you want to palpate for the trachea, because you want to check if any tracheal displacement over the opposite side. This going to the opposite side of the injury. So for this patient, because of the injury over the left side, so the trachea, when you want to check for the trachea, they will displace towards the right side. Okay. Next, your percussion. So for your percussion, so we will do. And for this patient, there will be a hyperresonant over the left side. Okay, hyperresonant, resonant, hyperresonant, resonant, hyperresonant, resonant. And last is the auscultation. So you will use your stethoscope. So you will hear there will be a reduced breath sound over the left side. Reduced breath sound normal, reduced breath sound normal, reduced breath sound is normal. Then you finish your auscultation, don't forget you need to check also your other vital signs like your BP, pulse rate, SpO2, respiratory rate. So in this patient having the tension pneumothorax, most probably they will have low BP and tachycardia, hypotension and tachycardia. So from the collection of this finding, one of the patient is tachypneic, and the sign of the reduced chest expansion over the left side, distended neck vein bilaterally on palpation, reduced chest expansion over the left side with the displacement of the trachea to the opposite side. Then on the percussion, hyperresonant over the left side, and auscultation, reduced breath sound over the left side with the low BP. Most probably this patient is having tension pneumothorax. Okay guys, now I will proceed with the intervention for the tension pneumothorax. For the tension pneumothorax, there is two interventions. One is the immediate intervention, and one is definite intervention. So when you for the tension pneumothorax, you need to do the immediate intervention. Before this, for the you need to do the needle thoracocentesis. Before this, they ask you to put this to put the needle over the second intercostal space mid clavicular line. But since the latest ACLS guideline from the 9 and 10 edition of ATLS, they ask you to put the needle thoracocentesis of at the safety triangle. So first, before we want to see for the safety triangle, I need to show the landmarks. So there's a 3 landmark for the safety triangle. First is your lateral border of the pectoralis major. So like this, lateral border of your pectoralis major. First. Second landmark is the 5th intercostal space at the nipple line, and the third landmark is your mid-axillary line. Okay, so like this, you can see there's a lateral border of the pectoralis major, the nipple line, the 5th intercostal space, and also the mid-axillary line. So for you to put this needle thoracocentesis, you use the large bore branula or large bore needle, and for you to put immediately go directly perpendicular to the patient chest. So you palpate over the intercostal space, usually over the 3rd or 4th intercostal space. So you take this branula, so you just go anterior to the anterior axillary line. So because it's still inside the safety triangle, so you go straight to the patient. Then after you inject, then you leave it trocar. Then you will hear the hiss sound. So what do you mean by the hiss sound? So you release the pressure from the patient chest. Okay, because there's a tension pneumothorax. Okay. Then after you put this needle thoracocentesis, then you need to go for the definite intervention, namely is chest tube incision. Okay. So you still put your needle thoracocentesis, then you go for the chest tube incision. So for the chest tube incision, yes, you need to put in the landmark of the safety triangles. So first, you need to make around 2 or 3 centimeter incision over the patient chest. So mainly here I want to calculate is around 4 intercostal space. So you make 1 incision. So later you use the arteries, then you already make the incision. So you go to inside the subcutaneous tissue. So slowly you will dissect all the subcutaneous tissue until you reach over the costal margin, where there's the in between the ribs there is a intercostal muscle. So then after you reach over the just next to the intercostal muscle, then you will puncture. You use your artery forceps, you puncture the intercostal muscles just above of the patient's rib. So you open up, you puncture, then with the finger So with the finger, we need another assistant. So using with your fingers over there. So you use your artery forceps to hold at the tip of your chest tube. You need to remove the trocar. Then you guide this one according to your finger into the patient, example, then into the patient chest. So you need to push upward, upward anteriorly and upward and okay. So next, so after that, so you can connect this chest tube with an underwater seal. For the underwater seal, you need to put some amount of water. There's a lemak over there. So you need to fill up to 300 mils. So you already put the water inside the underwater seal. You put on the floor. Then you connect it to your chest tube. So after you put your chest tube, next you will to confirm the chest tube incision, there's a correct placement inside your pleural space. So you will ask patient to cough. If patient cough, they will see there's a bubbling inside the patient underwater seal. Okay. Then later, after you already put your chest tube, confirm there's a chest inside your punya pleural space, there's a bubble inside your underwater seal. Next, you need to suture your anchor your chest tube over the patient's chest. Then after you anchor, after you suture, then you can put the plaster to make sure it's keep on the patient chest. Okay guys, we go for the second condition, second life-threatening condition, namely the open pneumothorax. Okay, for the open pneumothorax, the presentation same as your tension pneumothorax. So with the inspection, but the different with the inspection. So during inspection, when you open the patient chest, even the patient is tachypneic, so they will see the some open chest wound, or here we call it open sucking chest wound over the patient chest. So if you can see, this one is about 3 times 2 centimeter, so over the patient chest. Then for the other presentation, there's a tachypneic on this patient, reduced chest movement over the right side. There's a distended neck vein. On the palpation, they will reduce chest expansion over the right side. Over the left side. When you palpate for the trachea, so the trachea will be displaced to opposite side over the right side. Then again for your punya percussion, so percussion they will hyper resonant over the left side, and during the auscultation they will reduce breath sound over the left side. So we go for the intervention. So for the collection of this sign and symptom, this patient having the open pneumothorax. So what the intervention that you need to do? You need to do the 3-sided occlusive dressing. So you can see this wound around 3 times 2 centimeter. For even this one can be having the then you can hear some there's some bubbling, or even you can see hear the breath sound, air coming out from this from the wound. So what you need to do, intervention. So you need to use the plastic, not the gauze. You need to use plastic, the sterile plastic. So usually we can use this sterile gauze swab plastic. So you remove. Then how you want to apply? You just put this plastic over patient chest. Okay, so like that. Then I said you need to do the 3-sided occlusive dressing. So you will put the you have the 4-sided of this plastic. So you just need to plaster on the 3 sides only, like this. Okay. Okay, so you recovered, you replaster over the three-sided, so you leave another one side to act as the one-way valve. What do you mean by one-way valve? The air can slip out through this plastic during the expiration, but during inspiration, this plastic will cover and then we close this chest wound. So this three-sided occlusive dressing will act as the one-way valve. Next, later after you put this three-sided occlusive dressing, then you need to proceed with your chest tube incision. Okay guys, so we go to the fourth injury, the massive hemothorax. Okay, so you need to remember just now the tension pneumothorax, there's a leaking of the air inside the pleural space, but in this massive hemothorax there's a lot of blood volume coming out into the pleural space, so we will involve the circulation assessment also. So for the massive hemothorax, the presentation, patient will come with tachypnea, patient looks lethargic in pallor state, so because of loss of the bleeding, loss of the blood into the pleural cavity. So patient come with the tachypneic pallor. When you open up the over the patient close, then you see over the chest. For example, we take this is injury over the left side of the chest. So the patient presented with the tachypneic. Okay. Then over the inspection over the chest, you will see there's a reduced chest movement over the left side. Then over the neck, you can see either there's a presence of the distended neck vein or they will be absent. Absent because a lot of volume was been lost into the pleural space, so they may not see any distended neck vein. Then you go for the palpation. So for the palpation, so they will reduce chest expansion over the left side. Then check over the neck. You will need to palpate the trachea. So during this time, same thing like your tension pneumothorax, when you palpate the trachea will be displaced and will be shift to the opposite side, going to the right side. Okay. Then for the percussion, this side will become stony dullness over the left side, normal over the right side, and for the auscultation, they will reduce or they will absent breath sound over the left side. Okay, and don't forget you need to check for the patient vital sign, because we will involve the circulation. So you need to check for the BP, heart rate, respiratory SpO2. For the BP, maybe they will cause the hypovolemic shock. Then the BP will be dropped. Then also they will causing the tachycardia. Okay. So, okay, then intervention for the massive hemothorax, you need to do chest tube incision. Okay, and at the same time for the circulation part, don't forget you need to put the 2 large bore granula, mainly over the intercubital fossa. You need to run the 1 liter of warm crystalloid to replace for the blood loss. Then at the same time you need to assess all the vital sign. Then you need to see is it this patient in the hypovolemic shock, either in the class 1, class 2, class 3 or class 4. If patient in the class 1, class 2, you still can replace with the crystalloid, but when already in the class 3 and class 4, you need to straight away use the blood product and start blood transfusion as soon as possible. Okay. So for the intervention for the chest, for the massive hemothorax, you need to put the chest tube. I already show you the chest tube during intervention for the tension pneumothorax. It's still the same application, but there's a difference when you want to save this patient having the massive hemothorax. Okay. So for example, okay, so I already show you during the chest tube incision during the tension pneumothorax just now. So I just shortcut. Okay. So okay. Example. So next, so you already put your chest tube. So you want to connect to the underwater seal. So when we want to say this patient is having massive hemothorax, when you connect to the underwater seal, there's a 1.5 liter of blood coming out into the underwater seal. So if more than 1.5, we say this patient having massive hemothorax. Okay. Next, not only if not only that 1.5 during the first when the first drain of the blood. Next, you can also say this patient having the massive hemothorax when there's a drain of the blood more than 200 cc of blood, 200 ml of blood in the 2 or 3 consecutive hours. More than 200, like the second hours 300, third hours 400, the fourth hours become 500. So if also like that, also we call as the massive hemothorax. What the difference with this massive hemothorax? This patient may need we need to refer to the cardiothoracic team, because most probably this patient having the blood vessel injury, major vessel injury inside the patient chest, that patient may need to go for the thoracotomy. Then will be done by the cardiothoracic team. Just for the simple hemothorax, so we just enough with the put the patient on the chest tube, drain the blood, then we will replace the blood with the your punya crystalloid or your punya blood product. Okay. Okay guys, next for the fifth left ventricular condition that you want to check during the breathing is tracheobronchial injury. So usually the tracheobronchial injury, it can be either is a blunt or is a penetrating trauma to the neck or the upper chest. Okay, then usually for the presentation for this tracheobronchial injury is first around 20% patient having hemoptysis. Of course later patient will be tachypneic and in the respiratory distress. Next, this patient most probably you can see there's a lot of bleeding from the patient neck or the upper chest. So this tracheobronchial injury, they can be subtle presentation because you may not to see immediately the presentation, or either this patient most probably already passed away, already died at the scene of the injury. Then on clinical presentation, this patient either you can see there's an injury of the, you can see the injury, the wound over the patient neck and the upper chest. Next, you can see there's a subcutaneous emphysema. So how you see subcutaneous emphysema, where you palpate over the patient neck and over the patient chest, you can feel the crepitation over the patient chest. And next, patient most probably we having the around 70% patient will have pneumothorax. Okay, so and to diagnose this injury, the best is need to use the bronchoscopy, because from the bronchoscopy, so we can see the patency of the bronchotracheal tree. Okay, so the management, usually this patient yang having this tracheobronchial injury already passed away because of very bad injury over the neck, over the head, over the upper chest. If able to come to the emergency department, so usually in a very bad condition, so usually during the airway itself we already intubate the patient. Okay, so but there's a special about this intubation for the patient with the tracheobronchial injury. So what do you mean by special? Because maybe there's an injury over the patient trachea or the upper carina region, so we may need to intubate directly and to pass through. Either you can using the rigid scope, fiber scope intubation, then you need to pass through the trachea, because the problem, if the problem with tracheobronchial injury, the problem with the airway, with the breathing, patient unable to, the air or the oxygen cannot go through the lungs because the injury over the trachea. So you may need to pass through the ETT direct into the for example, if the injury of the left side, so you need to pass through to go to the one side, or we call it one lung ventilation. So if you go straight the ETT, pass through the tracheal bronchial injury over the wound side, you go straight to the one side for the one lung ventilation. So with the one lung ventilation, so that they still having the gas exchange over the one side of the lungs. Okay. Then another thing, usually this patient also, like I mentioned before, is 70% having the pneumothorax. So presentation of the pneumothorax same as before. So you need to put the chest tube incision. But when you put the during the tension pneumothorax, you expect when you already put the chest tube, the lung will expand. But for this tracheobronchial injury, you do the chest tube, then you repeat the chest X-ray, the lung is not expanded. So you think most probably this patient having this tracheobronchial injury. If other sign, you can see also for the tracheobronchial injury, when you put chest tube, then you connect to the underwater seal, there's a continuous bubbling of the gas of the air coming up into from the inside the underwater seal. Compared to tension pneumothorax, when we asking patient to cough, then there's a bubble. But with this tracheobronchial injury, then we see this continuous bubble with the patient breathing. That's maybe the sign suggestive of the patient having tracheobronchial injury. Then sometimes we may need to have the second chest tube on the same side of pneumothorax just to drain out the air from the patient chest tube. So you need to put side by side the chest tube. Okay guys, so I already complete my breathing assessment. So if this patient didn't have any breathing problem, just mild tachypneic, there's no sign symptom of the tension pneumothorax, open pneumothorax, massive hemothorax or tracheobronchial injury, don't forget to give the patient the high flow mask. Okay, we put the high flow mask, then connect to the oxygen wall. Okay, next I will go for the circulation assessment. Okay, so circulation assessment and the bleeding control. So for the circulation, make sure, the same thing also, you will need to go for the your punya inspection, palpation, percussion and auscultation. So mainly for you to check for your circulation part, you want to see any injury over the internally or any external injury. Okay, start with the circulation assessment. So circulation assessment, as you know, they can lose the blood internally from the thorax. Just now we will assess during the breathing, but don't forget circulation over the abdomen and the pelvic region. So over the abdomen, you need to palpate the patient abdomen. So for inspection, any bruises of the abdomen. So for the palpation, to feel any tenderness, deep tenderness over the patient abdomen. Then auscultation, any any bowel sound or present or absent. Then for the abdomen assessment, you have the primary survey adjunct, namely the ultrasound. So with the ultrasound, we can do fast scan. What is fast? Fast is the focus assessment sonography in trauma. What to do this fast is to assess if there is any free fluid inside the abdomen. So we can see the free fluid inside the abdomen. So we can say this patient having the intra-abdominal injury. So how to do fast scan, I will share you during the lecture. Then, so the fast scan. Next, you don't forget to check for your pelvic. So for your pelvic, make sure you just palpate over the patient pelvic. If patient complaining of pain, when you assess the pelvic, you just palpate the pelvic. So most probably patient having the pelvic injury. So what you need to do, so you need to to apply the pelvic binder. So pelvic binder, you have the pelvic sling, we have down there is the seam sling, just to close. So what the problem with the pelvic injury, we worry if patient having the open book fracture of the pelvic. So with the open book fracture, so you want to apply the pelvic binder or pelvic sling so that they close back, so that they have a lesser volume and put in the normal position, then reduce the blood loss inside the pelvic region. Okay, so that's the internally, there's an internal injury. How about the external injury? External injury, so you manage to see any long bone fracture. So long bone fracture from the upper limb or the lower limb. So if there's a, you need to assess any injury. So when there's injury over the there's a injury, there's a wound and bleeding from the wound, what you need to do, you need to stop the bleeding by you directly compress using the gumji over the patient's injury. Okay. If there's a lot of bleeding or having the exsanguinative hemorrhage from the wound, so you may need to use the tourniquet. Okay. Okay. So that's the assessment. And another one condition, one life-threatening injury that you need to check during this circulation is the last or the sixth one, the cardiac tamponade. So for the cardiac tamponade, so there's a triad, we call as the Vicos triad. So for the Vicos triad, then we having the muffled heart sound, hypotension, and third is distended neck vein. So with these three Vicos triad, so this patient most probably having the cardiac tamponade. Okay, so cardiac tamponade, you do check your vital sign during your circulation. After you do your assessment, don't forget to check your vital sign. So you need to connect this patient for the cardiac monitor, put patient on the BP cuff to check for the BP, then check for the respiratory, check for the SpO2. Then don't forget your peripheries, feel your peripheries. Is it patient is warm or cold, and the pulse volume, is it cool, good pulse volume, or there's a feeble pulse volume. Okay, so then for the cardiac tamponade, so then you proceed with the you see this assessment over the patient, there's distended neck vein. Okay, distended neck vein. Second, you check for the BP is dropped, hypotension. Then when you do the auscultation over the chest, you hear the heart sound is become muffled. It's very you unable to clearly hear the heart sound. Then how you want to confirm your punya your cardiac tamponade? You need to use your ultrasound to do the echocardiography. So with the echocardiography, you will see the circulation of blood, collection of fluid inside the endocardium. Next, the intervention for your cardiac tamponade, you need to do the pericardiocentesis. Okay, so pericardiocentesis, I just show you how to do it, but not you don't need to practice, or we not have any practical session for this pericardiocentesis. Okay, so pericardiocentesis, you need to go to pericardium, then you will extract the blood from the patient pericardium. So how you do it? You need the very long needle. Always we have the preparation for the for this pericardiocentesis set. So how you want to do it? So okay, you need to the long needle. Then how you go? So we go through the, this a different approach for your punya pericardiocentesis. There's a apical, this under the over the epigastric area. So over the epigastric area, xiphoesternum, you need to have the 2 finger breadth below the patient punya below of the patient sternum. Then you will pointing this needle straight below the patient. The needle straight towards go downward 45 degrees. Then you already enter into the patient chest. Then you will go straight into the patient left over the left shoulder. So you pointed to the left shoulder, you go inside. Then with the help of the monitoring of by the ultrasound and the cardiac monitor, then you will extract out the blood from the patient pericardium. The general intervention for your circulation assessment. So after you assess your abdomen, pelvic, any long bone injury, so you need the intervention during the circulation is you need to put the 2 large bore branula. To put 2 large bore branula over the intercubital fossa. Then you need to run fluid replacement. You need to run 1 liter of warm salines to hydrate back the patient. So then don't forget you need to check for the vital sign, BP, pulse rate, SpO2 and respiratory rate. Then you need to assess is it this patient was having any hypervolemic shock, then which class patient was in. There's 4 classes of the hypervolemic shock. For the class 1 and class 2, you can start with the crystalloid first, but with the class 3 or class 4, you need to start to give the blood product as soon as possible. Okay, then after you give 1 liter of fluid, then you need to reassess again the patient. Is it patient is fluid responder or non-fluid responder? So with the fluid responder, what is mean? The BP will pick up after your fluid 1 liter. If the fluid unable to pick up, so you may need to give another crystalloid, or you may need to start to transfuse blood product. Okay. Thanks. Okay, now I proceed with the disability. So after you complete your airway, breathing, circulation, so you go for the next step is disability. So during disability, 2 things that you need to check. 1 is GCS, 2 is the pupil size and relativity. Okay, so GCS there's 3 component. There's a component of eye component, verbal component and the motor components. Maximum is E4, V5 and N6. So you assess the patient GCS. Next, you want to check for the patient pupil size and relativity. Okay, so if one side of the pupil is dilated, so we may to suspect this patient may have left side. For example, left side is having the dilated or having the mydriasis or dilated pupil. So we may suspect this patient having the intracranial bleeding over the same side. So we need to proceed and need to send this patient to do the CT brain. Okay. Next, after finish your disability, you need to go for your exposure. Okay, exposure and environmental control. So during this time, you need to remove all the patient clothes. Then you need to properly check any other injury, small injury that you may miss during your punya ABCD. Okay, so including during your exposure, you need to do the load roll. What do you mean the load roll? You put patient on the, you try to lift up the patient one side. Then you need to check at the behind of the patient. If you want to see any wound, any injury of the back of the patient. Okay. Then after finish your load roll, then after finish your assessment, you already complete your primary survey. But remember, this injury can become dynamic process. Is mean even though you already complete your airway breathing circulation, patient may have later having the problem again with the airway. Then you need to go back to the airway to the assessment. Then you need to treat the injury that time. Okay, so then after you finish your A, B, C, D, E, your airway breathing, circulation, disability, and exposure, you need to do your adjunct of primary survey. For the adjunct of primary survey, you need to do the X-ray, radiological, the chest X-ray, the AP chest X-ray, and the AP of pelvic. Okay, beside. Then after these two radiological imaging, then you can at the same time another one is your fast scan. Don't forget fast scan. So you got 2 X-ray and 1 ultrasound. Then you can put your you can put the patient rest tube, or you can put patient on CPD. Okay, that's all for the primary survey.